Thank you, President Rakita, and a warm welcome to everyone logged in today. We are honored to have with us today Professor Suranjith Seneviratne as our guest speaker for this evening. And we really appreciate and thank you, Professor, for taking time off your busy schedule to talk to us today and educate us on this very relevant topic. Professor Suranjith is a professor and consultant in clinical immunology and Allergy Institute of Immunity and Transplantation and Health Services Laboratories in London, UK, and the University College London. He is an international expert in immunology, autoimmune, allergic, and mast cell disorders, and immunogenetics. He is also the director of the Center of Mast Cell Disorders and the president of the UK Sri Lanka Immunology Foundation, which is an organization that contributes to immunology and allergy education in Sri Lanka. He completed his basic medical degree at the Faculty of Medicine, University of Colombo with first-class honors, 8 distinctions and 10 gold medals, and was placed first in his year. Thereafter, he completed his MD in internal medicine and trained in clinical immunology and allergy at the John Radcliffe Hospital in Oxford, following which he completed a Doctor of Philosophy in Molecular Medicine at the Weatherall Institute of Molecular Medicine, University of Oxford, as a Commonwealth Scholar. Professor Suranjith has authored over 260 journal publications, where his insights has been published in American Journal of Medical Genetics, American Journal of Human Genetics, Journal of Experimental Medicine, and Journal of Allergy and Clinical Immunology. So it must be said that Professor Suranjith has achieved all of this at a very young age. Actually, he's just in his early 50s, am I right, Professor? And he's a person who always finds time to help others in need at this time. And personally, I would like to extend a personal note of gratitude to you for all the support and advice you give me as well. I now take great pleasure in inviting you to address us and give us the latest update and insights into the COVID-19 vaccines. Over to you, Professor.
Thank you, Tushari. Thank you very much for the introduction, and thanks a lot for all the nice words. It's been a pleasure to join you all and give you all a sort of update on what is happening around the world with regards to the COVID-19 vaccines. So if I could start off, I will try to take things, sort of try to make it basic so that everyone could understand, and not try to make it too technical, but you could always ask questions after that, after my talk. So these are the number of cases of COVID that have been seen around the world. You can see there have been close to 4.5 million deaths. So it's a big problem. And still there are people who say that COVID doesn't exist. I mean, the infection doesn't exist. And we know that it's a devastating condition. It has changed our lives for over a long period of time. UK, the US, China, India, Brazil, etc. were affected quite a lot. China started at the start of the pandemic, and then Sri Lanka, which was doing very well, had a spike of cases with Delta coming, because that is a tricky variant, and that is the one that we should nail down using vaccines, using sort of social distancing measures to be able to get over this pandemic. So all of you would know this structure. Why the reason I put this in here was just to show you the spike at the surface of that virus, which binds to the cells. So the virus has to enter a person, it binds to the cells, mainly in the throat and in the back of the nose, and then it multiplies. It has to multiply, spread from cell to cell, and then spread from one person to another. So during that process of multiplication and spreading from person to person, that virus can change. And that is the reason we get these variants. And the lower transmission we have, the better chance of reducing these nasty variants arising. Now, what is the implication of that? The implication is that if we allow only certain countries to be vaccinated while other countries don't have a proper vaccination program, or if social distancing is not correctly carried out in certain countries, then we find that variants can arise in those places, and that can jeopardize the vaccination program around the world. And that's a very important consideration to have when deciding global policy. So the vaccines are also directed against the spike protein that is found on the surface of the virus, and you can see the spikes on the surface. Many vaccines are in development. 8 have been approved, 5 have been abandoned. And that's very important to realize that not every vaccine that started their development process was approved or authorized. Certain vaccines failed. The Australians ran into a problem because the vaccine that they put a lot of money into failed, and they had to get rid of that vaccine. So, and as a result, they ran into vaccine shortages. So, although the process is very rapid in developing the vaccine, none of the steps were missed. All the steps are followed, and 8 have been approved so far around the world. Different countries have vaccinated at different rates. And this is an old slide just to show you that Israel vaccinated the population very early, and they increased very early, but then they released the brakes. So that shows that vaccination should go hand in hand with social distancing measures, because this is a respiratory virus. And if people come together, the chance of there being transmission is there. So they released the brake, and they are, especially when Delta was coming through, and there has been a spike, and that's the reason that Israel is going for a booster. They have already started the booster program to boost up the immune responses against the Delta variant, which I will talk again. This is a fairly newer slide, and you can see the countries that have vaccinated a lot of their population. United Arab Emirates is there, and what they did was they vaccinated very soon with using the Sinopharm vaccine, and now they're going for a booster with a Pfizer vaccine. So they did not look on and wait. So a good proportion of the population has been vaccinated in certain countries, as given in that slide. So what I want to tell you is that more than 5 billion people have received, around the world, have received at least one dose of vaccine. But that is not enough. We have to get more to parts of the world that have not been vaccinated appropriately. So the summary of this talk will be a quickly touch about the immune response, because that will give some perspective. What are we looking for in vaccination, about the variant, especially the Delta variant, and then give you an update about the latest facts with regards to the vaccine that has just come out in the last week, and that's very, very current. So if you look at the immune system is the defense system that tries to get rid of viruses, bacteria, fungi, etc. You have the first part of the immune system, the innate immune system, and the second part, which consists of antibodies, white cells, and something else called complement. We won't go into too much detail about complement. So antibodies and white cells. If you get an infection, those will be produced, but they take time. They take about 7 to 10 or 14 days. And the idea of getting COVID to get immunity is not a good idea, because lots of people, especially the older population with comorbidities or immune deficiency, will die during that process. So that is where vaccination comes in, because if you can get that immune response with vaccines, then you can protect that group of that group and the others in the population from getting this infection and getting severely ill with this infection. So one important thing that is used with regards to the immune response is a chemical called a cytokine, which is basically, we use language to communicate with each other, signal, English, etc. The immune system uses cytokines to communicate with each other, just chemicals. And the cytokines can be dysregulated or increased. Certain cytokines can be increased during COVID infection. And an important cytokine is a cytokine called IL-6. I won't go into detail, but just to mention this. Now, what is the importance of knowing this? It's because the treatment that we use when a person gets COVID and severe COVID and goes into hospital will be based on what we have learned about how this virus causes disease. So dexamethasone, tocilizumab, and other drugs are targeted to this increased levels of cytokines that happen during this process, or the cytokine storm, as we will put it, that occurs in some patients who get COVID. And that is the dangerous part that we want to manage and neutralize appropriately. So the immune response, as I told you, consists of antibodies and cells, white cells. Antibodies are IgG, IgM, IgA, different antibodies. We won't go into great detail, but those happen after an infection. Those will develop after vaccination. That's what we want to happen. Good levels of antibodies. Cells develop, CD4 cells, CD8 cells, but types of lymphocytes, white cell, that develop, and that again, we want it to happen after vaccination. And the better levels we get, the better protection you would have following vaccination. This slide has been put in to tell you that the older the person is, the poorer the immune response. If you are younger, the immune response is better. So we have a duty to protect those over a certain age. The 80-year-old, the 90-year-old are at extreme risk of COVID-19, of dying from COVID-19, if they get the infection. And early on, lots of people were hesitating to vaccinate the older population. But if you look at the Queen, 95 years, was vaccinated very early, and you wouldn't give a dangerous product to the Queen of England. So the important thing that is to be remembered is that the older the population, the poorer the response is, and those are the populations that should be given the vaccine early. Special precautions should be taken with regards to social distancing in that group. And secondly, they may need boosters before anyone else because they are at high risk of different complications following SARS-CoV-2 infection. So that's some basic aspect about the immune response. You can get it after infection, but many people could die, and that was what Sweden tried and shelved it after some time. So what we try to do is go hand in hand with vaccination and social distancing. Now, the virus is not going to remain dormant, sitting around to be destroyed. The virus wants to spread from person to person, and while spreading, it can vary, it mutates, and then we get the variants coming in. And that is the origin of the SARS-CoV-2 variant. So there are many variants that have developed, over 5,000, but of those variants or changes, as you would say, it's a handful that are dangerous, that can affect different aspects of our control or the immune response. So this has been written in great depth. Many authors, including who have written some aspects here. And at the present time, the main variants, the variants of concern that we take note of is alpha, beta, gamma, delta. Because previously they were talking about UK, Brazilian, South African, Indian, etc. And that was confusing a lot of people. So now the WHO has come and said there's alpha, which is the original UK variant. There's beta, which was the South African, gamma, which was the Brazilian, and delta, which originated, the original country was India. So those are the variants of concern. Then we have the variants of interest, and that is just lower down. The effects that it has is less than the variants of concern. So that is how they have classified. I've done a small clip on this, sort of very short clip. You can get it from Tushari and look at this if you want to go into great detail, more detail about the variants that have been described so far and the effects, including the Delta variant. Now, the Delta variant was initially called the double variant, not because it has only 2 mutations, but it had 2 critical mutations. That is, those mutations that I've shown there, the letters, that were found in the place that the virus binds to a cell. So if it has those 2 mutations, it binds the cell better, it can spread faster, and that was why we found that the Delta variant spreads or transmissibility is 60% higher than the UK or Alpha variant. And the Alpha variant was also higher than the original Wuhan variant. So you can imagine, as time has gone by, the variant, the Delta variant, is very transmissible. And a simple thing to be remembered, if two people are 100 yards apart, that virus can't go across. If they come together, if when they're told to social distance, they don't do that, the virus is going to spread from person to person. There's no reason. The virus does not respect this person is an important person, not an important person, is a female, male, etc. It will spread. And that's the importance of social distancing. You may call it lockdown, you may call it curfews, etc. But respecting that process, because when transmission is very high, you can't only depend on vaccination, because vaccination, some people won't get vaccinated, some people may not make an immune response. So it has to go hand in hand with social distance. And at this present time in Sri Lanka, if people keep on mingling, don't use their mask properly, they keep on meeting each other at offices, etc., that process is not going to work properly, and the virus is going to spread from one person to another. And the risk is that a new variant can originate, and that is a big risk when transmission is high. So what are the effects of a variant? It can affect the spread. As I said, it can cause more severe disease. It can affect diagnostic tests. It can affect the drugs that we use, and it can affect vaccine-induced immunity. And all of us as immunologists or other doctors are concerned about vaccine-induced immunity. That is, if the vaccines are less effective against the new variants, that is not good, because the whole vaccination program then falls down, because you have to keep on vaccinating, or better vaccines, etc. So these are the 5 things that we look for when you get a new variant. So finally, I come to COVID-19 vaccines. We have the immune response, we have the variants, and the COVID-19 vaccines. Again, lots have been written around the world by different authors. All of us have written about this. These are the vaccines that are, I've given the characteristics of some of the vaccines that have been authorized or approved. And you can see at the top, the Pfizer and Moderna, the best vaccines around. In a clinical study, we call it efficacy. In real world data, it's called effectiveness. And you can see the efficacy was very high with the Pfizer and Moderna. Below that came the AstraZeneca, the J&J vaccine, and the Sputnik vaccine. And below that came the Sinopharm and the Sinovac vaccine. All the vaccines are very effective against severe disease. That's what we want to prevent first during a pandemic, because if the disease is severe, people will get into hospital, ICU, it overwhelm the medical service, and people would be dying. That is the first thing we want to do with the vaccines, and all vaccines can do that, some better than others. So those are the characteristics of the vaccine, as I put there. The cost varies, the temperature variation. I've spoken about this before. I won't go into detail, but most of the vaccines, except the J&J vaccine, are 2-dose vaccines. So both doses are essential. That is very important. One dose alone is not sufficient. So as I told you, you get infected. You can be asymptomatic without any symptoms, or you can develop disease, where you develop mild disease, just some nasal congestion, a headache, fever, cough, etc. Or it can be severe condition where the lungs are affected, fluid leaks into the lung, cytokine storm occurs. So what we want to prevent is that severe disease. That's the first thing, and all the vaccines have been able to do that. Mild infection can occur, and we must remember that both mild infection or asymptomatic and disease can cause transmission. So you may have a very mild infection and go and meet someone of your relative and transmit that condition, especially if that person is not vaccinated. And that's an important concept to remember, because infection, we thought the vaccines were going to be wonderful with infection. However, with Delta variant, that does not seem to be the case. It's very good with disease. That severe disease is very good, but even it's a lot of people who are vaccinated are getting mild infection, and they are transmitting the infection to the non-vaccinated persons, and they are the ones who are ending up in hospital and getting into ICU, etc. And that is what is seen presently in the UK and around the world. So as I told you, efficacy is clinical trial data, but clinical trials are very, very enclosed structure. That is, they are very controlled studies. So we really want to know effectiveness, real world effectiveness. And that is why Israel, UK, Germany, US, etc. gave us lots of information about effectiveness of the vaccines, the real world. And I'll talk about the latest data. The UK followed this protocol where they vaccinated, they went very stringent to older people with immune deficiency, and they completed the program by February, and it was effective. This was the picture we found. If you could remember, November, December, we had a lot of cases coming up with the alpha variant coming, but with vaccination and proper social distancing going hand in hand, you found the curve coming down. They released and the Delta variant came in, and there was a bit of a issue with that as we were talking before the presentation started. So Los Angeles County study very recently, from May to July, unvaccinated people, when compared to vaccinated, had 5 times the rate of COVID-19 infection and 29 times more likely to be hospitalized. So this is the problem that the US is having at the moment, because a group of people are not getting vaccinated, and they are ending up in hospital, especially with the more transmissible Delta variant. 2 vaccine doses are needed for optimal protection. Very, very important. Don't wait for Pfizer. If you can't get it, go ahead and get any vaccine that is approved and available. Because waiting, I know a number of people who have waited for the Pfizer as a first dose, and whilst waiting, they have got the infection, and now they are having some severe complications. So 1 dose has, even when it comes to an excellent vaccine like Pfizer, had only 33% protection. While 2 dose, when you get 2 doses and 14 days after, you get the protection, the effectiveness increases very much. So the effectiveness against Delta is lower than the effectiveness against Alpha. And we have to remember that Delta is around the world. Delta is the one that we should concentrate at the moment and not get a new variant coming in. So Pfizer 1 dose, Oxford AstraZeneca 1 dose is not sufficient. 2 doses are needed, because if it's 1 dose, it's less than the WHO threshold value of 50%. Now, what about the long-term efficacy? So we got 2 vaccines. That's what we are pushing. But how often would we need a booster? When would we need a booster? Would we need it every 2 years? And that was a bit uncertain about 2 to 3 months ago. But new studies have come up, and these have been just reported in the last week or so. The Pfizer midterm efficacy trial showed a risk reduction in infection. That is, after the second dose, you're completely vaccinated or fully vaccinated, 14 days after the second dose. It was 2 months after receiving the second dose, it was 96.2. But by 4 months, it had dropped to 83. So there was a 12.5 point increase in risk of infections as time goes by. And this is why people are thinking of the booster dose coming in at some point. The Zoekovitz study, which you would have heard about, it got the data because they had an app which people who were vaccinated were completing. They got the vaccine data from December to July and the infection data from May to July. 1.2 million test results and participants. Protection of 2-dose Pfizer and AstraZeneca they found that it is beginning to wane off within 6 months. And when they modeled it, the worst, sort of reasonable worst case scenario is that the protection could fall below the cutoff level of 50%, especially in elderly, the immune deficient patient and healthcare workers by winter. And that is why they're targeting that group of patients, the people, to give them a booster dose before winter starts. This was in the UK, and this would be across the world. The US is following, and several countries have already started a booster vaccination program. So this is very new data that was published very recently with regards to the waning of the immune response. So again, putting it in another way about preventing SARS-CoV-2 infection, that is effectiveness after second dose, you can see with Pfizer at 1 month is 88%. At 5 to 6 months, that is 4 months or 5 months later, it had dropped to 74%. Still over the 50. Oxford AstraZeneca, it was 77. It started at a lower level and then dropped further after about 3 months to 67%. So these are important considerations when making policy decisions for a country. In addition, again, the Oxford Office of National Statistics and the Department of Health study was just reported again in preprint. With the Delta variant, the Pfizer and AstraZeneca vaccine, it provided good protection, but the effectiveness was definitely less than Alpha. So it is definitely, Delta affects vaccine efficacy and effectiveness. That is because real world is effectiveness. We have to remember that.
President Pakita, can we mute? Sorry, Professor, you're on mute.
Professor, we can proceed. Sorry for the...
right, okay, sorry. So 2 doses of either vaccine had the same level of protection as having COVID. Now, previously what we said with the vaccine protection was far better. When you get 2 vaccine doses, the vaccine protection is better than even having COVID. That was what was mentioned before when it came to the Alpha variant. Now we are finding it's similar. Vaccine protection is like having COVID. It's at similar level. So therefore, the take-home message is Delta affects vaccine effectiveness. So that is why, in addition to vaccines, social distancing, etc., is so important, because you cannot only put your money in the vaccine jar. You must look at both together. And the other take-home message, important take-home message, was those who got the Delta infection after receiving 2 doses of vaccine. So you can receive 2 doses of vaccine and still get a breakthrough infection. That person may get a mild infection, and that person won't end up in hospital. And that's what we are really trying to do initially. During the pandemic, we don't want them to go to hospital. But the problem was that the viral load in that person, say I've got 2 vaccines, I get a breakthrough infection, the viral load is high. So if I'm not careful, I will keep on spreading. It's the same as a non-vaccinated. I will keep on spreading this virus to the non-vaccinated, to children, etc. And this is an important fact to be remembered with regards to Delta, because if you get a Delta infection post-vaccination, you'll have a high viral load in your throat, at the back of your nose, and therefore you will be a reservoir of spreading this infection. So person will be fine. The person will be asymptomatic or very mildly, but they'll be walking around, going all over the place and spreading the infection. And a lot of people who are older, who are not been vaccinated, or people who have been, or children or immune deficient patients will be put at great risk because of that process. This is not the case with the Alpha variant. The UK variant, the Alpha variant, we did not see this, but it is what has been found with the Delta variant. That is an important take-home message to remember. So what I've done during this sort of 25 minutes or so was gave you an overview of the immune response. We are looking for antibody and cellular responses following vaccination. We can get it after SARS-CoV-2, but many people will end up in hospital and it will overwhelm the system, or the people will die. So we are giving vaccination, but vaccination alone is not sufficient. It should go hand in hand with proper social distancing measures that cannot be ignored. If we allow viral transmission to go very progress very extensively, you will develop variants that could be dangerous. And that is what people are very nervous. So far, Delta is tricky, but if you get a variant that is even trickier than that, that can cause major mayhem around the world. And then we have 8 vaccines that have been approved so far. Some vaccines are better than others, but we have to remember that vaccine effectiveness is not the same as vaccine, the adverse effects, because when I see some patients in Sri Lanka, a number of them are nervous about certain vaccines, saying, those are dangerous vaccines. No, the Sinopharm, the Sinovac vaccines are not dangerous, meaning it's like taking paracetamol and codeine. Codeine has paracetamol and another medicine, right? So the codeine may be better in relieving pain in one person. It doesn't mean, maybe better than paracetamol, but it doesn't mean that paracetamol is dangerous. So that's an important consideration to remember. So if the Sinopharm vaccine is not as effective as the Pfizer vaccine, it does not imply that the Sinopharm vaccine is dangerous. It just means that you may need a booster earlier. And if that is the only vaccine around, and you can't get any other vaccine, it's far better to get some vaccine and get some immunity rather than having no immunity. And that's an important take-home message, because people have been waiting and waiting for specific vaccine and getting COVID in the interim and getting quite bad. Thank you.
Thank you, Professor Suranjith. Now I would like to open the forum for questions. If you have any questions, you can, it's a time for you to ask questions from Professor Suranjith.
Good day, Professor. My name is Anil. Thank
Hello,
you
Anil.
so much for making time to be with us. It was very articulate and very easy for us lay people to understand. And thank you again. I have just a personal level. I have had 2 shots of AstraZeneca, and currently I'm in the USA. So I have an opportunity to get a Pfizer shot if I want as a top up, but I have to do it by the middle of September. I got my second AZ shot in May, middle of May. Is it too early for the top up, or should I wait till December?
There are a few factors to be considered, Anil. Why won't you ask Tushari for my number, and why will you text me? The reason I had to ask a few other details, because we have, when we go for the top up, I mean, over the just as a quick answer, I said yes, go for the top up. But I just would like to get a few more details, because we have a 3-month, 4-month for one group and a 6-month to 8 months for another group. Can I just answer that question by asking a few more medical details, etc.? But that might inform me, because again, if you're coming to, if you're there, you can get it. So can you get the number from Tushar and just text me, and I will answer that question to you with a few more details, please.
Thank you, Doctor. Yeah, thanks.
Okay.
Suranjith, Rohanta here.
Yes. Yes, Rohanta.
There were some reports coming that there are variants that has happened from the Delta variant itself. It was announced by the government. Have you heard of this? And
Yes.
is it, because when we talk to the people who are in places like Badul, which is very bad, they are saying that that is one area where one of these variants may be what you were talking about. I'm not sure. That's why I thought I'll just ask you.
Good question, Rohanta. So, as I said, there are more than 5, the SARS-CoV-2 virus has had more than 5,000 variants or changes occurring since the pandemic started. Of those variants, certain ones are called variants of concern, and Delta is one of a variant of concern. However, there are other variants which are called that, such as Delta Plus or the Lambda or the Epsilon. So Delta Plus has been described. It was found in Portugal. It was noted in Portugal, in India, and it spread. There was a few cases in Sri Lanka. And at the time, I wrote a small article to the CT. I think about a month ago, there were about 10 countries at that time that had affected. So yes, if there's an additional mutation to what is seen in the Delta, then it is called Delta Plus. And that is where there are certain areas of the virus that can be mutated. And if they are critically mutated, you can get additional mutant. And we don't know what is in store for us. And that is why we have to get this transmission down in all parts of the world, because otherwise you'll suddenly find another variant coming out. So with regards to variants, you can describe a variant, but then you have to do studies to see whether they are relevant. Because if you have 5,000 variant, you have 5,001. Tomorrow you can describe the 5,001, but it may not be clinically relevant. They have to correlate the clinical manifestations of that variant, clinical effects of that variant with the variant that is described. And that is a process that has to be followed, because otherwise it's just going on, what somebody said or hearsay sort of information. So that scientific process has to be followed. But it has to be taken seriously, definitely. You can't just ignore it.
Professor, yes, Dr. Vijay, do you have a question to ask?
Yeah, yes. This is Dr. Vijay, Dr. Suranjith. Now, I just want to ask you, there are some people, they got the first Covishield vaccine in last, 2020 February, March.
It can't be March 21 February, March,
yeah,
because February 1. Yeah.
So then they have not taken the second dose, saying that it is very dangerous and everything. What is the situation of that? Now the immunity must have gone. So
absolutely. As I showed you in that slide, one vaccine dose, that is clearly shown in the Oxford study, again, that came out very recently.
Yeah. And
the ONS study, one dose is not sufficient, because just look at it, go step back. What does a vaccine do? The first dose will produce an immune response. That's what is expected. In some people, it may not, but in most, it will produce immune. What are you doing with the second dose? You're boosting that response. Say initially, if the antibodies increase to, I'm just taking very random values, I'm just plugging it from the air. If the first dose gets it to 20, the boost will get it not from 20, it will go up to say 70. So that is essential. That boost is essential. In the UK, they want to give many people the first dose, so they did put a period of 10 to 12 weeks. That was the other reasons also. But now with Delta, they have reduced the interval to 8 weeks. It's not 10 to 12 weeks, because the getting the two doses are far more important than the interval. So therefore, they're going for that is, I know in Sri Lanka, when it comes to certain vaccines, it's 4 weeks, but getting the two doses. So you don't want to get it too soon, because then someone might ask, okay, I got one vaccine today, can I get it in a week's time? No, that is too fast, because you want the immune responses initiate, get to a level, and then you want to boost it up. And that getting only one dose puts them at high risk of getting COVID and all the effects with COVID.
So in that case, they have to start from first dose again.
If they had it in February, not that they will have no immune response, but from the studies we have seen, it drops down. It starts, with one dose. If two doses, if it's waning after 6 months, imagine with one dose, what is the profile, right? An individual. Yes. So therefore, I think they'll have to get properly vaccinated. Absolutely.
Right. Okay, thank you.
Professor Suranjith, this is Dushania. So this is a follow-up question to what was just being discussed. So over here, we had a situation where the AstraZeneca dose was given in February 2021. And then due to a shortage of vaccines, the next batch of vaccines of AstraZeneca came about after 5 months later. So that's about 20 weeks instead of the 4 weeks that you just mentioned. So therefore, my question is, what is the I mean, we understand about the efficacy of what you were mentioning in your presentation. Very well done, and thank you very much for that. So when you take the second vaccine after 20 weeks, and many people, I believe almost 100% of the people who took the first vaccine in February were administered the second vaccine after 5 months, 20 weeks. So there's a large population in Sri Lanka, almost like 1 million people, who have got the second vaccine after 20 weeks.
Yes.
So
Yeah.
therefore, the question is, should that vaccine be considered as their first vaccine, and then another third vaccine be taken within that 8 weeks to have the real efficacy, or whether life is okay with this gap of 20 weeks for the second vaccine, because there are 1 million people floating around in the country with that in that scenario.
Yeah. A very, very good question, and there are several sort of aspects to look into that that process. So, I mean, in the UK, they gave it between 10 and 12 weeks. That was the interval to give the second AstraZeneca vaccine. When it came to other countries, they went for a 4-week. The period that was assigned in the clinical trial, that was used in the clinical trial, but it was 10 to 12 weeks. Now that appeared to be okay with the Alpha variant. That was a variant that was in the UK, and there was a study that came from the Oxford University saying that even after 24 weeks may be okay, but that was at the time that a different variant was circulating, and that must be considered, because when these study reports come and sometimes reported in the paper, it can confuse because the context may be wrong. So that study showed, okay, it may be okay, but it was a different way. With Delta coming in, the UK government found that they should reduce the period, and that has been proven with the study that came from Oxford again, that 8 weeks is far better than extend the period. So now you come to the question of 20 weeks of people getting the second dose after 20 weeks. Now, I would say, because some people ask me, should I get the second dose? Yes, definitely. Even at 20 weeks, it's definitely better to get the second dose than getting nothing, because there's some boost. But do you think, immunologically speaking, we have discussed this as immunologists, do you think the boost will be less and may not be sufficient for Delta in the long term? May be okay in the short term, but in the long term, yes, we think that there may be a drop-off of efficacy in the long term. And that is the group that people have to discuss, should they be given a booster, either with AstraZeneca, but I would prefer a booster with a Pfizer, a better vaccine, right, as a booster dose. And so that group of a person may be the ones who should come when they decide, when the country finally decides we're going to give a booster dose. That may be the group that should be put in with the other patients to get a booster at an earlier stage than the person who received the vaccine at the correct period after 10 to 12 weeks. So I hope that answered, because there are several aspects to look at, because other consideration, because do we have enough Pfizer? Do we have enough AstraZeneca? Do we have enough other vaccines? Those have to be taken into consideration. It's very easy to just mention some, but then you have to see what is the availability. But definitely, if you give a second dose after a period of time that is a bit longer than what was recommended by different countries, used by different countries, you have to think there's a drop, there's a fall off of immune response, and that may be you're starting at a lower level, and then therefore the drop off can be faster or can occur sooner, and therefore a booster may be needed at an earlier stage in that group of people.
Thank you.
Did I give you some sort of clarification on that, some sort of direction?
Absolutely. I've been trying to get that clarification from many people, and I think you clearly explained what the situation is. Thank you very much.
Okay, thanks.
Thank you very much.
Suranjith, so what happens if you find that the policymakers are not actually using data for decision making? Like, I mean, in Sri Lanka, they want to tell the world that it's better to immunize people between 30 and 60, and they forgot the research shows very clearly that you have to target, like what UK did, a very organized process of going 60 plus first. So in the absence of, I don't know whether people are listening to research or whether the people who know the research is not saying it. None of us know actually what the truth is in Sri Lanka. In absence of this, how do we take a decision practically to the question that Dushan asked?
Duranta, you asked very difficult questions. I mean, the expectation, around the world and in Sri Lanka, you have lots of people working in the area and giving data across. I mean, the only thing we can do is now, I can give global data. Those working in Sri Lanka will give Sri Lankan data plus global data. In other countries, Hong Kong said they will also give global data. And the expectation is that global data is listened to, and you can learn lessons from other places. Now, when it comes to managing, say, a condition like hypertension, sometimes you can't just transfer knowledge in, say, the UK or the US directly to the person in Sri Lanka. And that's why we always say, okay, we have to look at our population. Not that this differs in SARS-CoV-2, but we can learn something from other countries. If something has happened 6 months before in another country, rather than trying to reinvent the wheel, what we should do is, okay, what are the good things that happened there? What are the things that UK did right? What are the things that UK did wrong? How do we take the good, forget the wrong, and to forget the bad? So I think the idea is that people like we who are in the field, intimately in the field, as immunologists, as allergists, we are intimately in the field. So we follow this on a day-to-day basis. The importance is for us to inform and try to put it in as easy way for people to, because otherwise the same sort of process can be given in such technical language that people would not know whether alpha is, what is alpha or beta. So to give it in easy language, but then the others who are making the decision, because sometimes there can't be a disconnect between those making the decision, the final decision, and the people telling what is happening around the world, including what is happening in Sri Lanka. And that is a thing, I think, if both the policymakers will listen and question, I think there should be not just listening, there should be a questioning process, because just because some data comes in, you don't just accept it. You look at it, you look at it critically. I mean, good example is ivermectin. People are looking at it critically. So take that, but then once the good practice is identified, put it into place and put it according to how it happened in the place that the good practice it worked properly. I hope that, because I just do not know otherwise how to get the two people, because like now in my case, I'm not making policy, but I'm informing what is happening around the world.
Suranjith, I think you're one of the respected people from all whom I have listened to. I have a lot of respect for you, and I mean today you could see it very clearly coming through, like what PDG Dushan was also saying. Just one final question. It's on the kids. See, now, in the alpha and before Delta came in, we found that the kids were not getting COVID. I mean, the spread was very much lesser. But now we see the kids are getting, and they're also dying. So, the mortality rate is high. So my question is, in this context, when you have we are not actually not very strong in our vaccination program also. So when do you think, I'm not actually asking a date, but any kind of research that has been done, when do you think schools can begin?
So again, there are two sides to that question. Definitely children, when few adults were vaccinated, right, the children, if they got COVID, most of them got mild COVID. A few got the severe multisystem inflammatory involvement. However, with Delta coming in, plus since a lot of adults in many countries are getting vaccinated and has some immunity, you're finding that children, they can be the people, more children are getting affected around the world. And we have seen that in the UK, US, etc. Now, the initial question was, should we vaccinate children? Because, we are doing it to protect the older population. And is that fair? That was one question. But now the data is showing that more children are getting infected from several countries. The data is coming. So and secondly, their education is getting affected because they're not going to school. I mean, internet classes are good for a certain period of time, but mental affections are occurring. They are not socializing. They are not meeting people. So that is the reason several countries have taken the step of saying we are going to vaccinate children. Now, originally the vaccine was approved for 16 and above. The Pfizer vaccine was approved for 16 and above. All the other vaccines were 18 and above. So there had to be studies first. I mean, they were expected because, you don't want to just give vaccines for children without proper studies. So they did the studies. Pfizer did it. Moderna did it. AstraZeneca did not proceed. So AstraZeneca is not a vaccine to be considered for children. And the Chinese vaccines also, they have approved it from 3 to 17. So countries like Canada, sort of US, etc., they are vaccinating a group of, so over 12, they have approved the vaccine and they are vaccinating the children. And because they have started school or they just started school and they want to vaccinate from starting from the oldest children, going down to up to 12 years, not below 12 years because it has not been approved. In the UK, so far, they have taken a middle path. They have said we'll vaccinate 16 and 17-year-old. Previously, they said only high-risk groups, but then they changed it because they found that the amount of infection in that group was again high. So they vaccinated 16 and 17. But with the new data coming up, the likelihood is they will vaccinate up to 12 years because there's a lot of pressure coming. There are two groups because what the two groups are, you have to balance it. What the WHO is saying is correct. Certain countries in Africa, certain countries in Asia, you don't have health workers have not got a single vaccine. And then you are vaccinating your children while we don't even have vaccines for healthcare workers who are in contact with patients with with COVID. You all are trying to vaccinate people, giving a third dose and a fourth dose, etc., while other people have not even had one dose. Is that a fair process? So that has to be balanced. And if you had enough and more vaccines around, it's very easy, vaccinate this person, vaccinate that person. It's an easier thing, but the supply is limited and the demand is definitely increasing. So I think those have children will be vaccinated at some stage, but the rollout, the pace and which, and the country will have to decide. We can now say in Sri Lanka, if you ask, should they vaccinate over 60s or children? I mean, it looks like first vaccinate the over 60, but that is the group is also in a problem. So vaccinate both together rather than because the over 60s are at high risk with comorbidities. And there was a question, there was a sort of a position taken, my mother is 80 years, she doesn't go out of the house, so therefore she can't get COVID. But, Sri Lanka is a country where we meet, children don't wait, they go and visit their parents very frequently, maids go, the drivers go, other people go into the house, and they can be double vaccinated, but they can transmit the infection to the person who is at high risk and of getting very, very severe. So I think children and now in the UK, the older population has all got the vaccine, but those populations will have to be looked with the immune deficiency cohort.
Professor, this is Dushan again. Sorry, I have a second question to you. This is, with public interest in mind. In the UK, now you have announced that, UK government has announced that at border control, you are allowed inside only with the Pfizer jab, with any other Pfizer both jabs. So I don't know whether AstraZeneca is also part of that inclusion or not. So that's the first question. Second question is that coming this September, as you know, there's a lot of intakes to the universities and undergraduates as well as the postgraduate courses, and number of students are looking to come to UK. And some of them have already got the Sinopharm, which is the popularly given vaccine here, both jabs. Now, such students, especially the postgraduate students, is it safe for them because they can't enter UK with the Sinopharm jab? Is it safe for them to take the 2 Pfizer jabs along with that? Because they do give you the Pfizers in Sri Lanka. If you go with the university entrance letter, they give you the Pfizer jab. So that means they'll end up with 4 jabs within a period of, let's say, 16 weeks inside their body. So therefore, my first question is about the Pfizer and the AstraZeneca entry into UK. Second question is, those who have already got vaccinated with 2 jabs, whether they can, whether it's safe for them to take 4 jabs because they have to enter UK.
Very good question, Dushan. I think extremely very pertinent and very topical question. So looking at the now, I mean, there are geopolitical positions that come in with the vaccines with regards to the vaccines produced in China, in Russia, in the UK, US. Different people posture in different ways. What happened to the AstraZeneca vaccine and Europe when the different vaccines. So different sort of governments or regions put in rules and then down the line they change it. Now, if you look at that concept, now if you're in the UK, going to the US won't allow you because if you have got 2 AstraZeneca, you have to get Pfizer. So that is a big problem. I mean, so far they won't allow, unless a special category from the UK to go to the US. That sort of transfer is not allowed at the moment. But the UK has said that any vaccinated person from the US can come in here as long as they have 2 negative tests. So there's a lot of sort of posturing that is going on at the moment. Like the European Union said that if you have had the Sinopharm Sinovac vaccine or the AstraZeneca, the Indian version of the AstraZeneca vaccine, they won't allow a person to come in. So there has been this issue which tends to get sorted out as time goes by, because initially it happens, everyone is shocked, but then at a very high level within governments, or they put in the documents, etc. In the European situation, they had not evaluated the Indian version of the Oxford AstraZeneca vaccine. So that is so those tend to come up and then they tend to get ironed out after some time, because that is at a very high level. Now, with regards to the vaccine, so then there are students and other groups of people where they have to get on with certain activities, and then it comes to should they get 4 vaccines. Now we have data on 3 vaccines. Number of patients with liver disease, renal disease, etc., or cancers have got 3 vaccines, but we don't have a big amount of data on 4 vaccines. Although a few million people have in the US have just gone and got the vaccines without being approved, without a booster being approved, because in the US you just walk in and get your vaccine, and a few people have got 3rd and 4th dose vaccine. But we don't have robust data, Dushan, to say that 4. I generally say go for 3. But then if you're not allowed to go to a country, where do you stand? I mean, where do you because if you have to get both vaccine, we have to balance, we want to stimulate the immune system, but we just do not know that answer. Do we stimulate it too much if we give 4 vaccines during a very short period of time? And we still don't know that answer. If you ask me, and a lot of immunologists, we think that people around the world will need 4 vaccines at some stage, means 4 vaccines over a period of time. We'll need a booster 3rd dose and another one like the flu vaccine. Or most of us have got more than 4 flu vaccines during this period. But that process of getting it very, at 16 weeks, getting 4 vaccines is a tricky process. And that I know a few quite a number of children are getting into that category. If it was one Sinopharm, then I say, go and get the two Pfizer vaccine, that's fine. Then it's 3 vaccines, it's okay. But if and they are young, their immune response is good, etc. But if it is 2 Sinopharms getting 2 Pfizer vaccines, I think I don't have robust data to go by to tell you, okay, that's fine. That is absolutely fine.
Thank you, Prof. So is the AstraZeneca Indian version accepted in the UK?
India, yes, it is. Yes, I presume with Europe it's not, because Switzerland accepts it. UK, I think I may be stand corrected there, but I think the UK accepts it. But just check that up. Dushan, I just want to be, but I know Europe there was a number of restrictions.
Yes, one of our postgraduate is leaving end of this month to UK.
And AstraZeneca,
yes.
India is accepted,
Indian,
right?
Yeah. Yes.
Yeah, right. Okay, so that's I think
They got
in the UK.
Yes.
Exactly. In the UK, we were a bit surprised when the European Union said no, they can't accept because it is the same vaccine, right? Absolutely.
Professor, are people with any autoimmune issue, are we more at risk than others for this COVID?
Good question. Depends on the medication. So autoimmune per se means your immune system is not behaving the way it should behave. That's basically what is autoimmune.
That's the kind of thing I have, Suranjith, is that something I should worry about, or is that something mild?
So if the autoimmunity, definitely vaccination would be given early. That's absolutely. We would have targeted that group of the group with autoimmunity to get vaccination early. We would not delay it. The reason being is already the immune system is not acting in the way it should act. Secondly, with autoimmunity, there's a chance that you may need steroids or immunosuppressive medications, etc. in the future.
Those are very severe ones you're talking of, right?
Exactly. Okay. But even any mild autoimmune, I would encourage a person to get the vaccine early. That's the important, because having protection is far better than having some protection is better than having no protection at all.
Yeah. Okay.
Professor, I have a question to ask. Now, is there when it comes to efficacy, is there a difference between the Indian version of Covishield and the Oxford one? Why do they make a distinction between those two?
Exactly. We were not, it is the same vaccine. It is the same identical construct. The original, the base construct is the same. So there should be no difference between the two vaccines, just that it's made in a different place. And we have to remember the Serum Institute of India is the biggest vaccine manufacturer in the world. It makes 60% of all vaccines, right? So India leads the world in making vaccines. It is the biggest player. So, the world's leader is making that vaccine, which they license from Oxford. The issue, I think, that happened was that the European Union wanted each vaccine manufacturer of that to put in their documents in. But when things blew up in India, I think Serum Institute was more concerned in getting as many doses out to the Indian population rather than putting paperwork to the European Union, because that came second. But once the European Union evaluates it, almost certainly that it will be the same vaccine, because it will be the same efficacy, because it's the same vaccine. There is no change. The Indian company did not change the construct. They just produced the same vaccine. And if you get your measles, mumps, etc., the highest chances from the UK, anyone getting the vaccine, or Europe or Germany, etc., they'll be getting a vaccine made in the Serum Institute of India, because they are the biggest vaccine manufacturer in the world. They have really refined that process. So there is it was just a sort of a geopolitical, and they had not, it was easy for them to justify in one way. We didn't have the documents, so till we get the documents, we we cannot approve it. That will, same with Sputnik, same with the Chinese vaccines, etc. The Sinopharm and Sinovac. That is why they have the restriction. But at some stage, they will put in that data. It was like the WHO, the Sinopharm and Sinovac went for the WHO approval. They got the approval, right? While it took a long time for the Sputnik vaccine to go for to put their papers into the WHO. But it's the same construct.
Thank you, Professor. One other question. You referred to ivermectin. Now, we here discuss about prevention, but we see there are a lot of people who have got infected, and you correctly said that even though you have got the vaccine, still there's a possibility that you can get infected. Then is there any remedy or is a cure available, or are we working on something like that to cure people who have got infected?
I think people have been working from the start to try and find a medication. So if we take an example with HIV, they've worked for 25 years to find a vaccine, have still failed to get a vaccine. And that was the situation we were in around May 2020. People were skeptical whether we'll have a vaccine, but we got vaccine. And that was a wonderful, wonderful achievement. But for the treatment perspective, many drugs have come in: hydroxychloroquine, remdesivir, the monoclonal antibody cocktail, then tocilizumab, the other medicine. So they are doing different things. Now there are antiviral drugs, remdesivir, etc., are to affect the virus. That is what he's trying to do, affect the viral replication or the viral multiplication, where that is has to be given early. Then you have the drugs which affect the immune system, and these have to be tested. The important thing is, you have to have some evidence when you're doing it. Otherwise, you'll be going on the situation that happened with what Trump came across. Because Trump, he was tweeting every day saying that hydroxychloroquine was beneficial. And we found that was an absolute sort of took people down a wrong path. And we found that is not beneficial in patients with, it's beneficial in autoimmune disease, etc., but it's not beneficial in SARS. So therefore, scientists became very, very cautious, and they had to evaluate it, because otherwise you can produce adverse effects, etc., and especially with hydroxychloroquine. So lucky thing, one drug that was quite very important when it becomes symptomatic was dexamethasone, because again, it is important to have a drug that you can use which is cheap, because if you have the most expensive drug like the monoclonal antibody, some other monoclonal, you may not everyone around the world may have access to that. So you have dexamethasone, and then after that, now those are to affect the immune response, not the virus, the immune response, because in SARS-CoV-2 or COVID, you have the virus multiplying, but then the immune system gets out of control. Immune system goes mad. You want overact the immune system in a bad way. So therefore, they use dexamethasone, they use tocilizumab. There are other drugs that are being considered and are under trial. Very early, you have what is called the monoclonal antibodies. They are the pros and cons. So those have been used, and that's where things like ivermectin is coming in, right? Not at a late stage, but should it be given? And that area has been very controversial at the moment. Lots of discussions are going. Every day I see 2 or 3 clips going, one saying bad, one saying good. I've looked at the data, etc., but it's a very controversial area at the moment. And many bodies have not allowed it so far. But there are 2 big trials that are going on. The study in the UK, that study is going on, and the study in the US, and hopefully that will give us some information about its ultimate utility in this condition, when to use it.
Thank you very much, Professor. Do we have any other questions? Because I think we have already exhausted him with so many questions. But
yeah, President Rakita, I'm Vicky from Candy, past president. I have just a small question. Is it okay if I ask the Prof?
Yes, please. Yes.
I'm sorry about. Good evening, Prof. I have a small question. So now, always when people are talking about this AstraZeneca, Pfizer, or Johnson and Johnson, we'll say Sinopharm, and now you can see now in Sri Lanka we got very few thousands of Sputnik from Russia. Yeah. So now there is a rumor going. I mean, they are doing the second vaccine only for about 6 days, and there's a rumor going if you have the Sputnik and it has covered more than 75 to 80%. So, but you can have the second, or else if you don't need to have the second because it has already covered more than 75% about the vaccine. I mean, I like to know about what is it true or what the Sputnik works, how it works, and things like that.
So Sputnik, good question. I know in Candy they gave, and certain people were told to sign a document saying that they will only get one vaccine, right? So, yeah. I mean, we would love to have a single dose vaccine. That is why the J&J vaccine was taken on board by the Americans, and they didn't release it to any other. It was so difficult to get the J&J vaccine because it's so easy if you have a single dose vaccine, because the person gets a vaccine, and that's fine, absolutely excellent. And that's why in America, sometimes if you're taking a booster, sometimes they give the J&J just one dose, then you don't have to think of getting 2 doses of, as I will discuss in our outside forum. So the thing is that certain vaccines you do need 2 doses, and the vaccines include the Pfizer, the AstraZeneca, the Moderna.
Professor, can you unmute yourself, please?
Okay, so in that process, right, so Sputnik, all the data that there is a thing called Sputnik Light, but that has not been approved in Sri Lanka. So what was approved was the original Sputnik for 2 doses. And thus, if I personally think, if you are giving a 2-dose vaccine, it is like giving a Pfizer that has been approved to be given as 2 doses, because that's what was shown in the clinical studies. And then if we suddenly turn and say, I know the 1 dose is sufficient, that's okay, we don't need to give a 2nd dose. I mean, you have to show that process, and you have to give evidence to show that that is a correct process to go, and especially with something like Delta circulating around. I mean, we have to remember that transmission with Delta is extremely high. The UK, the US, the Germany, all over the world, Australia now, news. I mean, it is spreading. So with a variant like Delta, giving 1 dose of a 2-dose vaccine is not the sort of what would be recommended, unless a study has been done on Delta showing that 1 dose of vaccine is sufficient. You can't do a study on Alpha and say, because it has to be, you have to compare apples and apples rather than comparing disparate things, right? So I would say if it's 2 doses, that's the recommendation. 2 doses are what is expected. I think everyone is muted, so they may not be.
Yes, thank you very much, Prof. Thank you very much.
Okay.
Okay, I think with that, we will stop the question and answers forum, because we have asked too many questions from Professor.
No, it's wonderful. I think very, very relevant. Thank you very much, because they are so relevant. It's not theoretical questions. It's practical, day-to-day things. Absolutely.
Thank you very much, Professor, because it's a great privilege for us to have you on board. We have listened to so many speakers on the same topic. And I mean, we were able to clarify most of the doubts that we had, because as lay people, some of these things explained by experts like you, sometimes you don't understand. But here you were able to explain it in very simple and plain language in a way that we can understand. Thank you very much.
Thank you, and pass on the message. Absolutely, Rakita, because pass on the same message to others who had not been there, so that they'll also know the correct person. Thank you.
Absolutely, Professor, because we have recorded this session, so we will take steps to share this recording to the general public as well. And we have initially, I was planning to discuss about our project